Hello, I'm Paul Richards from the Australian Academy of Science. Thanks so much for sending in your questions about COVID-19. We'll aim to answer as many of them as we can during our webcasts, now held 3 times a week. You can ask a question in the comment section directly under this post on Facebook or YouTube. The views expressed in these webcasts are those of scientists we interview, and the scientist we're asking questions of today is one of our best known. Professor Peter Doherty shared the 1996 Nobel Prize for Medicine for vital discoveries of how the immune system recognises virus-infected cells. He's a Fellow of the Australian Academy of Science and a Laureate Professor at the University of Melbourne. Peter, welcome. Australia has tightened social distancing restrictions. What effect is that likely to have in response to this virus?
Hopefully a very good effect. It'll be a while before we see. We've had fairly strong social distancing. Some people have been observing it and some not. I mean, we've all seen the images of people on beaches and, people riding in cycling packs. I think you want to be out in front if you're in one of those because you're getting all the droplet spray from the front. But hopefully that will calm down. So I think it will have a significant effect, and we just wait and see. Because there's a lag phase. There's a lag phase of between the time you're infected and the time you show any symptoms is likely to be at least 5 or 6 days. And then by the time you show severe symptoms, it'll be a bit longer. So anything that happens now is reflected in what we see a week from now, depending. And we may not see that quickly because people may not sort of check in for medical help till they've been feeling ill for a bit.
Yeah, some people are also confused about how you catch COVID-19. Can it be transferred in the air or is it droplets of moisture from someone coughing?
I think it's pretty much droplets of moisture. We've just been discussing that this morning. You know that a number of healthcare workers have been infected and some of them have died. And I've been asking the question whether it's particularly the people in intensive care units. Intensive care units, there's a job of trying to intubate the patient, and that requires people getting right up close, and there can be a lot of droplets in the air, also small droplets, and these people are more susceptible to infection. So I would say that it's droplets in the air, and particularly anything that atomizes the droplets and makes them smaller. That wouldn't be a normal circumstance, but that we'd encounter, but that's maybe why the healthcare workers are at risk. In general, with respiratory virus infections, when we do experiments in mice with influenza and so forth, the higher the dose, the more severe the disease, unless it's a very, very severe infection. And then a very low dose can do it. But we haven't played around a lot with droplet size as far as I know.
And how long can the virus live on surfaces? Is it able to live for hours or even days?
Yes, we're told it can live on cardboard and paper for up to 24 hours. I don't think that's likely to be a major source of infection, but it's something you just might keep in mind when you're taking hold of the pizza box. Maybe you open the pizza box and then before you take the food out, wash your hands and then put the pizza box somewhere out of the way. On plastics, it can certainly survive longer. On plastics and steel, certainly survives for at least 3 days. And in the SARS epidemic, of course, we saw people wiping down elevator buttons and so forth for that. So if you're taking in plastics, again, you might want to spray them with something or just open everything, wash your hands before you take the food out of the plastic, maybe transfer it to another plastic bag before you put it in the fridge. It can survive up to 9 days on plastics.
Wow, that is such fascinating and interesting and practical information. I mean, we're given clear social isolation measures. Everyone is washing their hands and following that basic advice. But I think to have that awareness of how long it can live on these different surfaces and to be mindful when we're receiving food or other packages at the door, those extra steps could further help slow down transmission, couldn't it?
I think they're all things to keep in mind. I mean, we've all got quite a bit of time on our hands at the moment, and we can all think this through. And I think the way you bring food into the house is an issue. It's not nearly as big as an issue as being near someone who's coughing and spluttering, for instance. Now, and I don't think being out in the fresh air is any great risk at all, I suspect. That's why the mask issue is a difficult one because, I don't know whether you've had much experience wearing masks, but depending on how good a mask it is, it can get kind of wet. Dribble, snot, mucus, all those things that are so important, but we don't regard as being of great value, but they're very important. And if your mask is wet, for instance, and if it did get contaminated, well, then maybe you want to drop it down around your neck or something when you're out in really clear and open air, because you're at more risk from the mask. So there's always been a lot of dispute about the value of masks, particularly about not particularly high quality masks. And the N95 masks haven't been easy to come by, and there are a lot of other masks out there that would not be so good. So I think they're very important for healthcare workers who are up close. I'm not so sure they're that important for the rest of us, but if you've got a good mask and you feel comfortable with wearing it, by all means do.
How often should you replace a mask?
Again, there's a problem replacing them because there's not enough of them around. So if you look online, you'll see all sorts of recipes for sterilizing them. One easy one, I think, would be if you have several of them, leave it for 3 or 4 days out in the sun. Sun will probably kill this virus pretty effectively. But there are people talking about using peroxide. And again, when you look at the recipes for doing something with it, think of what sort of mask it is, whether it would survive the treatments they describe.
Now, New Zealand has chosen to go into a nationwide lockdown for 8 weeks. In Australia, we have been, measures have been slowly but surely tightened. Which is the most effective, and is it actually different for different countries?
Well, there are a lot of, I'm an experimental scientist, so there are a lot of experiments out there, some very bad ones. I mean, the American experiment and the Italian experiment and the Spanish experiment look to be bad experiments. I mean, obviously, the virus got away in all those countries before they realized it was there. I think it had been around in the US for 6 weeks or so before they got those first deaths in the Washington nursing home. There's some evidence that that's true. Now, if you look at the map of distribution of virus across America, it was in the New York Times yesterday, you will see that every state is infected. And there's a lot of, for instance, infection in the rural South. So that's not a good experiment. The New Zealand, we're in the middle, and we're waiting to see what the results of our experiment are. The case reports have dropped. That may be because we're now taking people straight off planes and putting them in hotels, and I'm not sure we're testing them. I'm not sure of the regimes in the different states. We're going to test them at some stage, I expect, before we let them out, but we may not be testing them straight in. So they're there for 14 days. If they're infected now, they'll have symptoms in 5 or 6 days or be virus positive. And so if they were all tested, say, in 10 days, that would probably tell you whether they're infected or not. So that's another experiment. Now, New Zealand and Israel have both instituted very, very tight border controls very fast. So they may keep it out largely and stop it from circulating in the population. The downside for them is going to be when do they turn it back on again, because they won't have any herd immunity developing. And quite frankly, if they wanted to stay completely safe, they'd have to wait till they got a good vaccine. So it's a difficult thing. I think our strategy is mostly directed at the idea, yes, we will have community transmission. It's probably too late to avoid that. And the numbers we're seeing now may be community transmission. That is transmission from people who haven't flown in from the country. It used to be we were looking at first at just direct contacts of someone who's just flown in. Now we're looking more broadly in the community. Some of the criteria have been relaxed. So I suspect the numbers we're seeing now are community transmission. That's the sort of transmission that can be handled quite well, I think, by the hospitals. And what we want to avoid is overwhelming the hospitals, of course. So hopefully we're in that sweet spot. We'll see what happens.
So that's really the decision that is being made by governments as to what capacity do their health systems have to have patients come through. Even with all these social isolation measures in place, will a lot of the community end up catching this virus over time, do you think?
Yeah, well, that's what these experiments are going to show us. So we can look at that question in a month's time. There are various issues out there. Some people have claimed that the level of background infection rate in Spain, Italy, and England is is already 40 to 50% of people infected. Now, if that's true, if there's already 40 to 50% of people infected, and we allow a lag phase for those people, some of those people are going to develop severe symptoms. So that would take 2 to 3 weeks, say. So we allow 2 to 3 weeks and then a month. What we should see in a month in those countries, if we need a 60% herd immunity to slow down transmission, we should see a drop-off in cases. There should be a dramatic drop-off in cases from countries that reach that 60% level within a month or so of reaching that 60% level, or a bit earlier, because it'll phase in, obviously. The probability of infection will drop as you get more immune people. So that's one of the experiments that we'll be watching, is whether in a month or 5 weeks' time, we're suddenly seeing a big drop in case numbers coming into the system in the UK and in Spain and Italy. It's important to recognise that 80% of people are relatively mildly infected and certainly won't need to be hospitalised. In those that need to be hospitalised, they will get a lot of support. They'll get extra oxygen and things like that. Then at the very end of that, in the most severe category of the people who have to go into intensive care, they have to be intubated. And their chances are not great, actually, unless we find that some of the things that are being discussed now for reducing that severity work really well. And it's possible they will. But, you know, if intensive care intubation units run out, which they will very, very quickly, it will still be better for people to be in hospital under professional care and getting, say, additional oxygen and so forth if they need it.
How long do you think that Australians will be forced to stay in their homes under this strategy that is being put in place? The Prime Minister has warned us to be prepared for measures to be in place for 6 months. And what will allow life to start to return to normal?
Yes, it could be 6 months. It depends how quickly the infection goes here. Of course, the more slowly the infection goes, the more the economic disruption, in a sense. The quicker it goes, the more deaths. Okay, because people wouldn't be able to get adequate hospital care. But the slower it goes, the longer the economic consequences. I think this is an issue that will have to be discussed very seriously, because we don't really know. We've got more and more hints about background infection rates, because some people can be asymptomatic, they can still transmit, and others have very mild infection. So the initial figures that came out of Wuhan suggested a 2.5% death rate. Now that they've got a better handle on background infection, asymptomatic infection, they've revised that down to 1.4%. Okay, so, and I wouldn't be surprised to see them revise that even a bit lower. Now, what you've got to realise that all the testing that's been done so far pretty much has been by PCR. That's the looking for viral gene sequence, the same test, of course, that's used for rapists. And people have been ramping up those PCRs, getting more and more labs doing the testing, and actually making them a bit simpler too. There's a bit of an argument, and there are other tests too. Not quite as accurate, but 90% accurate. 90% is good, even probably 85% is good, because you can simply take the positives and recheck. You know, what you're worried about is the false negatives, of course. So PCR testing only detects virus. So all we've been looking at is a virus. Now, what you would normally look at if you want to know how many people were infected after an epidemic would be the antibody conversion rate. As this is a brand new virus for us, that's easy, because anybody who's got antibody against this thing has had the infection. But what we don't have yet is a screening antibody test for testing large numbers of people in big antibody surveys, and something like an ELISA test or something. These are all in development. That sort of test would be really, really useful. That will tell us the final background infection rate. Now, the reason I've gone into that is that once someone is serologically positive, that is, they've had the infection, they've got antibodies, there's no reason why they shouldn't live normally if we're sure that they're not excreting virus. And that's pretty unlikely, I think, even if they had a bit of virus in them. I think it's pretty unlikely that people who've been infected for a month, got antibodies, would be pushing out much virus. There may be a bit there detected by PCR, which is very sensitive, but I doubt if they'd be infecting people. So basically, after people are serologically positive, we should be able to let them go back to normal life. Now that will be, and start maybe phasing in the opening of cafes and restaurants. I've sort of been thinking, well, we need a sort of card that says, you know, I've lived through it. I'm a corona survivor or something. So you could show that before you went into a bar or a restaurant or a supermarket, because you'd be perfectly okay. You're not going to infect other people. You're not going to get infected. You're safe. And also, you could be a source of antibody, convalescent serum, which may be useful for prevention and therapy. And CSL is looking at that. So basically, the question for the politicians and the policy people will be, well, how soon do you relax those guidelines? Because once you do, you'll have firstly the antibody positive people coming out, and that's fine. But you're also likely to get a lot of the antibody negative people saying, I've had enough of this. Who's going to tell the difference? So it's going to be an interesting exercise in in mass psychology, I think, as much as anything else. Fascinating. Epidemics are always fascinating from the human behaviour point of view.
Yes. Now, Peter, the Doherty Institute is one of the world's research leaders and the first lab in Australia to sequence the COVID-19 genome. We've had a question sent in from our Facebook audience. Simon Schwartz asks, if a vaccine will take 12 months to develop, what role will it play in a pandemic that's already underway?
Well, you know, when you think about people being released back into the community, right, you know, I mean, one strategy was suggested was we should give all people between 20 and 35 a free air ticket to Surfers Paradise, evacuate everyone else from Surfers Paradise, give them free booze and free accommodation, let them get the disease, and we'd have a substantial immune population. That is not a very irresponsible strategy, but intellectually, it's not totally stupid. And of course, if they did get severely infected and die, young people can get severely infected and die. They probably die happy due to the alcohol consumption. That is also a trivial point. It's not true. People get quite sick. So the question will then be, once we get to that 60% herd immunity, the question will be how much community transmission is there? Because people like me, the over 70s and so forth, if there's any community transmission, are still at risk. So the question is, how soon can they be let out? Well, theoretically, they can't be let out if there's still community transmission until there's an effective vaccine. So though it may be we can restore a lot of people to normal life because they've had the infection, they've survived, and they can go about their ordinary business, then there are still those vulnerability groups. And that's the issue for us. And that's why the vaccine is really a top priority. But we have to move carefully with it.
Yes. Well, look, Peter, I could literally talk to you all day about this issue, and I really appreciate we've got so many questions that we'll be asking and covering with you as time goes on. I did just want to wrap up this particular conversation with asking you about the Academy's statement that was released last week, which highlighted 3 key points in response to this virus. It said that decisions must be based on scientific evidence, approaches must be international, not national, and beyond the current pandemic, there's a similar emerging threats to our future well-being for which we must prepare. Could you just, in your own words, tell me why you think these points are important?
Well, the first point, it must be based in science. Very valid. I think that's happening. I think our people, epidemiologists like Jodie McVernon and James McCall, for instance, are advising through various committees, advising the chief medical officer. And of course, there are other people like Raina McIntyre, we've seen a lot of on TV, who are also providing advice. So I think the scientific advice is being thought about very, very seriously. Then there are other issues, of course, about the balancing of it. How do you balance between total closure and so forth? It's partly economic. It's partly also how you actually handle this in the long term. Because if we manage to shut it down like New Zealand, which I don't think we can at this stage, but would be remarkable if we could, then we would again be totally isolated as a nation until we had a vaccine. So there's that issue. I don't have any problem with the way our governments are approaching it. I know there are differences in strategy between what the Prime Minister is saying and what some of the state premiers say from time to time. But basically, I mean, you live in a state, you're subject to state policing, so it's the state premier in the end, but they're all more or less on the same page. And if everyone took Scott Morrison's advice, we will certainly drop it down to much lower levels, I think. Second question is about the nationality of it. Well, internationality of it in the sense of exchanging reagents, trying to ensure that people aren't just cut out of supply lines, that we're getting World Health Organization coordinating various things, which they do to some extent through their influenza network and other networks, and acting as well as we can globally. Yes, massively important, but it's too late for a lot of that because all countries are in different situations. And of course, well, we're looking at countries like Spain and Italy and the United States, which have pretty good health services. The real horror of this is going to be in the developing world and in the poorer countries where there are a lot of people with comorbidities that are going to make them much more susceptible to infection. And of course, that's one of the reasons we're trying so hard to keep it out of our indigenous communities because of comorbidities and isolation, difficulty of getting people to hospital and so forth. So there's that issue. The third issue was what do we do in the future? Well, I think we're going to be looking hard at this for a long time. A lot of people are going to be analysing. Problem is people lose sight of things remarkably quickly. I wrote in a 2013 book on pandemics I published. One of the things is to try and watch out for these cost-cutting neoliberal type politicians who will cut out public health services. Some of that happened in Australia, in Queensland particularly. And I won't name the guy, but he's now doing something else who was leading the state at that time. You might guess his name. But that has happened, and President Trump, for instance, tried very hard to cut public health services. I think the Congress blocked him a lot on that, including the Republican Congress, which was fairly responsible of them. So I think we need a whole new approach. I think we need to rethink the way our society works, quite frankly. I think this society that's driven only by the needs of capitalism is a complete catastrophe. It's unsustainable, it's toxic, it's anti-human and just horrible. And I think we have to work out how we move on beyond this present poisonous economic model.
Well, Professor Peter Doherty, I think that is a strong note to finish on this discussion. We'll catch up with you again next week. Thank you very much for your time.
A pleasure. Talk to you next week.
And Peter will be back with us on Monday next week to answer more questions. But this time, Wednesday, we will have a special webcast featuring Academy Fellow Professor Edward Holmes. He helped crack the genetic code of the virus that causes COVID-19. I'm Paul Richards. See you Wednesday.